The topic that I'm going to be discussing today is nutrition support in cancer, and to try to convince you that it is oncologically logical. The objectives of my presentation are to give you an overview of the metabolism of nutrition in cancer, the assessment of the cancer patient specific to nutrition, review of a few studies, the use of adjuvant therapies, and I would refer to you several guidelines that have been published on this topic. Now, the first two items on the slide, are cancer patients malnourished, or does malnutrition result in complications? Are easy to understand, and the answer is obviously yes. So I'm not going to spend too much time on those, but I'm going to address whether outcomes will be improved if malnutrition can be treated. And therefore, is it logical to use nutritional support for cancer patients? Cancer-induced weight loss is multifactorial. There's an ongoing sarcopenia, or a loss of skeletal muscle. And this is because of tumor factors, as you can see in the green portions of the slide, increasing proteolysis, loss of lean body mass, and the body's immune response to the tumor, resulting in cytokine production, appetite, depression, decreased food intake, an increase in the CRP causing an increasing metabolic rate, and alterations in macronutrient and micronutrient metabolism. So we have the stages of pre-cachexia, of early inflammation and weight loss, then cachexia itself with systemic inflammation, and advanced cachexia where you have fat depletion, severe muscle wasting, and severe immune compromise. We have learned that there is a big difference between simple starvation and stress starvation. In simple starvation, you have breakdown of fat in sepsis, trauma, cancers, hypermetabolic states. Protein is broken down. Cancer is peculiar in that you have features of both. About 80% of cancer patients will lose weight, and 20% of cancer patients will die from the effects of malnutrition rather than from the malignancy itself. And when you have weight loss, there is increased toxicity of chemotherapy, decreased response to therapy, increased morbidity and mortality. Patients get readmitted to the hospital unnecessarily. Length of stay increased, and the quality of life goes down. Functional status also goes down. So I think it is important to know how to identify malnutrition in cancer. And expert panels, as referenced in this slide, clearly show that you can use any screening and assessment tool or modifications thereof to suit your practice. The malnutrition screening tool has been used. The GLIM criteria, the Global Leaders Initiative in Malnutrition, is being popularized. So it doesn't matter what screening tool you use, but malnutrition, when detected in cancer, must be put down as a medical diagnosis. And the incidence depends upon the tumor stage. In pancreatic cancer, it is very high, almost 90%. In colorectal cancers, 40 to 60. But it also depends on the stages. From the initial stages to terminal stages, malnutrition progressively becomes worse. And the causes are multifactorial. It is poor nutrient intake because of cachexia, mechanical factors, metabolic derangements because of tumor, or for therapy, about which I'm going to stress some more, and impairment of the GI tract function. But some cancer patients are well nourished before diagnosis and treatment, but they become malnourished during therapy. And therefore, our job is to make sure that at least during therapy, the malnutrition that occurs can be diminished. You may not be able to completely attenuate it, but at least diminish the effects of malnutrition. Let's take radiation. Radiation therapy causes mucosal edema, ulcers, malabsorption, altered taste. And in the late effects can produce fibrosis and strictures, obstruction, and perforations. The effect of radiation therapy can be aggravated by chemotherapy. Surgery produces malnutrition because of resection and bypass of the segments of the GI tract, post-operative complications such as fistulas and strictures. Chemotherapy affects malnutrition by cytotoxicity, the mucositis, the enteritis, the diarrhea, the electrolyte abnormalities that occurs from chemotherapy, the immunotherapy resulting in azotemia and fluid retention. Corticosteroids, quite often used in cancer patients, causes hyperglycemia, calcium losses, fluids and electrolyte problems, and also loss of muscle. A recent study showed that the chemotherapeutic agents we use affect gut function. Gut function is impaired, and therefore muscle health and daily functioning are affected. There is an adverse effect on the anabolic effect of feeding because of chemotherapy. And more important, disruption of the gut microbiome leads to inflammation and gastrointestinal mucositis. So now we go on to ask ourselves, does nutrition therapy improve outcomes, specifically in cancer? Now, studies are very difficult to conduct because randomization of similar patients, similar to age, sex, type of cancers, changing receptors is very, very difficult. And how are you going to able to have a control? It is not ethical to withhold nutritional support in patients with cancer. However, those studies that have been done have not shown a decrease in mortality. But what can be confirmed is complications of therapy, especially infectious complications when enteral feeding is used, is very clearly shown. And the planned chemotherapy and radiation therapy can be completed rather than stopping it in the middle because of the side effects of chemotherapy and radiation therapy, some of which can be attenuated by proper nutritional support. The effect of nutrition support in cancer has been shown to produce a better quality of life, better physical performance and function, better body image, maintenance of weight. The family is satisfied, and the patients don't have to die because of not only macronutrient deficiencies, but also micronutrient deficiencies and electrolyte imbalances, including magnesium and phosphate. Now, in head and neck cancer, several studies have shown that when nutrition support is used, quality of life is better, and the radiation therapy is completed without interruption. But again, no change in response rate or survival is shown. Here's another study showed the nutritional support on treatment delays and morbidity in patients with head and neck tumors treated with radiation. All supplemented patients showed an increase in weight gain, and the completion of planned chemotherapy in almost all the patients, whereas in the control, only 40% of patients were able to complete the chemotherapy. In cancer patients, it is important to think about preoperative enteral nutrition support. This has been known for several years, and here is a meta-analysis involving almost 2,000 patients showing that preoperative enteral nutrition decreases infectious complications, length of stay, no effect on mortality. And when I say preoperative, it is not only preoperative in terms of surgery, but also pre-chemotherapy and radiation therapy, at least 5 to 7 days before pre-procedure. Questions are often asked, will the nutrition support itself promote tumor growth? The results are conflicting. Most of them are lab and animal experiments, not with human experiments. And they deal with tumor proliferation and not tumor apoptosis or cell death. Tumor growth does not occur with parenteral nutrition, and clearly shown many years ago that tumor growth in humans is insensitive to the exogenous supply of nutrients. Therefore, don't let anybody try to convince you that by giving nutrition support, the tumor is going to grow. On parenteral nutrition, for example, this study on 20 malnourished patients with gastric cancer who are actually randomized to receive standard oral diet or diet plus parenteral nutrition, and they used a technique called uptake of bromodeoxyuridine by the cells, which is a marker of DNA synthesis. The conclusion basically is that parenteral nutrition does not stimulate tumor growth. So should we actually be using it because it does not stimulate tumor growth? We have to be very careful about it, because the benefits of giving parenteral nutrition in cancer is kind of not well accepted, mainly because cancers are highly variable and the quality of life is also more important. Now, this study just published a few weeks ago in matched controls of close to 500 nutritionally at-risk gastric cancer patients have shown that 3 to 7 days of preoperative parenteral nutrition had no effect on clinical nutrition, but it was actually very, very expensive. I agree with you, parenteral nutrition should be used where indicated in patients postoperatively when enteral feeding cannot be used. Now, but do we always think about parenteral nutrition in every patient? Well, this study on ovarian cancer patients have clearly shown that when you have inoperable bowel obstruction, there is no clear justification for parenteral nutrition in patients with ovarian cancer. In terminal illness, be very, very careful because you cannot delay death. It's different from prolonging life. In selected patients with good performance status, home TPN may improve the quality of life and body composition, but we have to be very careful about the ethics of giving nutrition support of whatever kind to terminally ill patients. Orexigenic or appetite stimulating agents have been used, especially migestrol, but remember, they can cause thrombosis. There is no effect on survival, and you should not extend it for more than 3 months. And there is some increase in weight gain, but not muscle actually, usually from fat. Anabolic agents such as testosterone and derivatives, the levels are low in cancer. And oxandrolone, a synthetic derivative, has been shown to improve performance and quality of life scores in cancer patients. Remember, the refeeding syndrome can occur quite often in cancer patients, but it is we had another talk on this already, and it is common but not recognized because the levels of electrolytes, including magnesium and phosphate, are not usually checked. Remember, refeeding syndrome is preventable and quite often in cancer patients. What about additional supplementation such as glutamine in fish oil? No proven benefit of parenteral glutamine, sometimes used for oral mucositis. And fish oil, again, the recent guidelines from the Academy of Nutrition and Dietetics in USA shows that if the patient's nutritional care and intake are optimal, and if weight loss continues, then consider fish oil supplements, but not routinely. What about neutropenic diets? A neutropenic diet is not necessary. Again, supported by the Academy of Nutrition and Dietetics. Only safe food practices and counseling are needed. So the conclusion of my talk is, providing nutrition to a cancer patient is a basic physiologic principle. It is a medical necessity. If the plan is to treat the cancer, then nutrition support is an integral part of the treatment plan, and therefore it is oncologically logical. Thank you very much.